Hi friends, so in this video we are going to discuss about right ventricular failure. As you know, our conventional teaching of cardiac physiology emphasizes more on the left ventricle, its structure, its function, and right ventricle is just considered as a conduit to let the blood pass from systemic circulation to the pulmonary circulation. But as we are gaining more and more knowledge and information about the right ventricular system, we are intrigued, and if the patient has a right ventricular failure in the critical care unit, probably the mortality is going to be much higher. And even if you diagnose a right ventricular failure, it is going to be very difficult to treat. So it poses a very big challenge in front of us in terms of diagnosis and in terms of management. And that's why I have decided to discuss this topic with you. So let's start. So one by one we will discuss under the following headings. First of all, we will discuss what are the differences between the right and left ventricle. We will also learn about ventricular interdependence. Then we will see what is the pathophysiology of right heart failure, and following that we will see what are the causes of right heart failure, with more focus on the critically ill subgroup. And in the end, we will discuss about the diagnosis and management of right ventricular failure in the critically ill patients. Okay, so now let's discuss how right ventricle and left ventricle are different. So if you look at the anatomy, the right ventricle is almost 2/3 or less of the size compared to left ventricle. On the cross section, if you see, it looks like a crescent shaped structure which is like a cap. It is sitting on the left ventricle. Both the ventricles are divided by the interventricular septum. In terms of thickness also, if you see, at the end of diastole, the thickness of right ventricular muscle is around 2 to 3 millimeters. Compare that with the left ventricle, that is at the end of diastole, it is around 8 to 11 millimeters. So there is a significant difference in thickness, there is a significant difference in size. And why is this so? Because when the RV pushes blood into pulmonary system, the afterload that it faces is much less compared to the LV when it pushes blood into the systemic circulation. Normally, as you know, the pulmonary systolic pressure is around 25 millimeters of mercury, and the aortic pressure, if you compare that, it's around 120-130 millimeters of mercury. So that is almost around 4 or 5 times the afterload that left ventricular muscles have to face. So probably that is the reason why the walls are not very thick, because they don't face a lot of pressure. There are some advantages and disadvantages. The advantage being, whenever there is a volume overload, because of the thin wall, it is a more compliant cavity. RV can dilate and accept more volume. And on the flip side, whenever there is a pressure overload in terms of increase in the afterload, then the right ventricle cannot respond to high pressures as well as the left ventricle, and it fails early. So that's the difference in terms of anatomy and how they respond to stress situations. Now, in terms of how they contract, so RV, the muscles of the right ventricle, contract longitudinally and result in a peristaltic-like flow of the blood, starting from the apex going to the outflow tract. LV, left ventricle, compared to the RV, the muscles contract in a circumferential fashion, and they propel blood towards the aorta. So that is another difference. And if you see the blood supply, obviously there is difference in the blood supply also. So most of the free wall of the RV is supplied by the right coronary artery in majority of the patients. Also, posterior 1/3 of the interventricular septum is also supplied by the right coronary artery. Since the RV wall is thin and the pressure is less, the intramural pressure is much less than the systolic and diastolic pressure which is there at the in the root of aorta. So right ventricle is supplied blood throughout the systole and diastole, compared to the left ventricle, which is supplied blood only during the diastole. So now we will discuss what is ventricular interdependence. As you know, both the ventricles, they are covered by the same pericardial cavity, and there is a septum which is shared among both the ventricle. So they are dependent on each other, and any change in shape, size or compliance of one ventricle will affect the shape, size and compliance of the other ventricle. Talking about systolic interdependence, when left ventricle contracts during the systole, the septum also contracts, and contraction of the septum helps the right ventricle push out blood during the right ventricular systole. Both the systoles occur at the same time. So left ventricular contraction and septal contraction contribute to almost 40% of the outflow from the right ventricle, and this is systolic interdependence. And there is also diastolic interdependence. So whenever there is pressure or volume overload on the right side, right ventricle, the septum is pushed towards the left side. This leads to smaller left ventricular cavity and reduction in the preload, obviously, because it is not filled as the earlier size, and this may lead to reduction in the cardiac output because of the reduction in preload. So that is diastolic ventricular interdependence. So this is about ventricular interdependence. Now let us discuss what is the pathophysiology of the right ventricular failure. So in the critical care unit, the most important cause of right ventricular failure is increase in the afterload. And if the increase in the afterload is acute for various reasons, which we will discuss in the coming time. So if the change in the afterload is acute, then the right ventricular cavity cannot compensate. It will immediately get under stress, and it will start failing. The right ventricular output will reduce, and it will lead to cardiovascular collapse. If the change of right ventricular outflow or the afterload part, if that is going on a long term and it is a chronic one, then the right ventricle will get some time to get adjusted. It will gradually dilate, thus increasing the preload to maintain the stroke volume. After reaching a certain level, it will eventually fail and develop a pressure overload also. And this will push the right interventricular septum towards the left side. As we discussed earlier, it will reduce the left ventricular filling and it will reduce the left ventricular output. At the same time, when the right ventricle is dilated, the tricuspid annulus is also pushed up and it is dilated. At some point, when it is dilated to a certain extent, when the tricuspid valve leaflets close, they are not approximated very properly, and it leads to tricuspid regurgitation. So when the changes are chronic, you may see that the patient may have a tricuspid regurgitation, right ventricular dilatation, pushing of the septum towards the other side, and eventually, if there is an acute insult on top of that, or as a part of the chronic ongoing process, this will eventually lead to left ventricular failure. So that's about the chronic part. Now either due to chronic or acute pressure or volume overload, there is increase in the stress amongst the right ventricular muscle. They have to pump harder to push blood, and as we know, it is a thin-walled cavity. It cannot withstand that increased demand of oxygen, and it will infarct. As we discussed earlier, the blood flow to the right ventricle is present during both systole and diastole, but when the right ventricular dilatation occurs and there is volume followed by pressure overload, the blood flow to the right ventricle is also compromised, and initially the systolic blood flow is compromised and only diastolic perfusion is there, and later the diastolic blood flow may also be compromised. So this is how the patient will develop a right ventricular infarct, eventually leading to decrease in the output and cardiovascular collapse. Now let us discuss the various causes of right ventricular failure, and our focus is more for the critically ill patients. As we discussed earlier, the most important cause of right ventricular failure in intensive care unit is increase in the afterload. So let us see what are the causes of increase in the afterload for right ventricle. And I think probably the most common and most important cause is pulmonary embolism. As you know, the pulmonary embolism will obstruct the outflow from the right ventricle, and this will lead to acute increase in the afterload and eventually right ventricular failure. If you see the ECG, you can see the right ventricular strain pattern, you can see RBBB, sometimes you can see S1QT3, which is quite specific but not sensitive for the right ventricular failure, for the pulmonary embolism, sorry. So that's pulmonary embolism. Another important cause is hypoxic vasoconstriction, hypoxic pulmonary vasoconstriction, which is commonly seen in any conditions causing hypoxia, but the point of interest here is ARDS. So it is like a protective mechanism. When the hypoxia is there, there will be vasoconstriction, and to facilitate more blood flows towards the more ventilated alveoli. But in ARDS, almost all the alveoli are affected, and so there is hypoxic vasoconstriction in the pulmonary circulation in overall the whole system, and there is acute rise in the pulmonary artery pressure, leading to high afterload and right heart failure. Mechanical ventilation itself is a very important cause for right ventricle. As you know, any positive pressure breath will increase the intrathoracic pressure. This will lead to increase the afterload for the right ventricle. At the same time, it will compromise the venous return because of the positive intrathoracic pressure, and this will reduce the preload for right ventricle. Both the things will eventually lead to decrease in the right ventricular output. For ARDS, if you give lung protective ventilation, probably the chances of damage of due to mechanical ventilation are less, and trials have proved that. So that's why that is one of the advantages of lung protective ventilation, that it is not too bad, not too aggressive on the right ventricle. So that's about mechanical ventilation. Another important cause is chronic pulmonary artery hypertension and chronic pulmonary vein hypertension. These are the situations which may be ongoing for a long time. There are various reasons for the pulmonary artery hypertension, and because of any acute scenario, it can suddenly present as acute or chronic pulmonary artery hypertension. Pulmonary venous hypertension, as you know, is secondary to your left ventricular failure, leading to passive increase in the pressure in the pulmonary circulation and increase in the afterload for the right ventricle. A new and interesting cause that I found is right ventricular failure secondary to cardiac transplantation, and it is a very serious and important factor. This happens to any heart when the person whose heart was not functioning probably would have had a dilated or non-functioning left ventricle, leading to back pressure changes and pulmonary artery hypertension, pulmonary venous hypertension, and pulmonary pressure would be high. When this patient has got a new heart from a recipient, this new heart in all probability is not accustomed to high pulmonary vascular pressure, and it faces a high afterload as soon as it is implanted, and this leads to right-sided heart failure, which is a big problem. And that's why measuring the pulmonary artery pressure is a very important step during the workup of heart transplantation, and high pulmonary artery pressure is not a favorable parameter for patients to receive a new heart. Second group of causes for right ventricular failure are reduction in the right ventricular contractility, and it can be because of the right ventricular infarct, sepsis-induced right ventricular dysfunction, which is moderated by the release of cytokines. It can also be because of cardiomyopathy, and rarely because of right ventricular arrhythmogenic right ventricular dysplasia. Now coming to the third group of causes, where the increase in preload is one of the cause, and in this group there can be pathologies of the tricuspid or pulmonary valve, like tricuspid regurgitation, pulmonary regurgitation. There can be atrial or ventricular septal defects which lead to right ventricular failure because of the overload. Another important and probably a new cause that is now being observed, and it is more relevant for us because we are more into practice of LVAD placements, is right ventricular failure secondary to LVAD or left ventricular assist device. And what happens here is when you put an LVAD, the failing left ventricle gets some support, but at the same time you have to remember that right ventricle is also failing secondary to left ventricle in these patients. And when suddenly you improve the left ventricular function, improve the left ventricular cardiac output, left ventricular output obviously, it leads to improvement in the blood supply, blood flow that is coming back to the right heart, and if it is already under volume and pressure overload, more incoming blood will lead to right ventricular failure. Also, when the left ventricle is effectively and efficiently emptied, it becomes a smaller sized cavity. This leads to movement of the ventricular septum towards left side, and it leads to loss of systolic ventricular interdependence, that is the help of the left ventricle during the systole to help push blood from the right side. So that is also lost, and both of these are the causes for right ventricular failure post LVAD implantation, and the cases have been observed in early as well as late stage, and it is a very important and newly found challenge which you should be aware of. Now let us discuss the diagnosis, how to diagnose right ventricular failure in your critically ill patient. And it is a very difficult diagnosis to make. For that you require high degree of clinical suspicion. Typically, if you see any patient with right ventricular failure will have typical signs like raised JVP, peripheral edema, congestive hepatomegaly, ascites, and hollow systolic murmur because of tricuspid regurgitation. But in right ventricular failure, which happens all of a sudden acutely in the critical care unit, most of the time these typical signs are absent. So that makes the diagnosis even more difficult. How will you suspect in that case? So you will suspect based on the various causes that we discussed of right ventricular failure. If patient has any of the causes and patient is in shock, you will suspect that whether patient has left or right ventricular failure, and specific diagnostic findings will help you come to the diagnosis. First of all, if you do an ECG for these patients, you may see right ventricular strain, right axis deviation, you may see complete or incomplete right bundle branch block, you may see P pulmonale because of high pulmonary artery pressure. You may also see R or S wave, which is more than 1 millimeter in V1, which indicates right ventricular hypertrophy. So these signs will give you clue that there is some problem on the right side. You may also see S1QT-T3, which is not very common, but it is specific for pulmonary embolism. So that also may give you some clue. So that's about ECG. If you do a CT chest, probably you will not know much about the function of the heart, but you will know that patient has some chronic pulmonary problem, which may be the cause of pulmonary hypertension. You may also learn about the size of right ventricle and right atrium. You may know about the pericardium, and these things may give you some clue that this patient is prone to have right ventricular failure. In the CT, you can also have get an idea about thickness of the right ventricle, and you can know whether there is right ventricular hypertrophy. So CT might give you some clue. If you do TROP-I or BNP or CPKMB, these markers are markers of the injury to the cardiac muscle, or the troponins and CPKMB, and the BNP is a marker of stretching or dilatation of the cardiac chambers. And I would say these are not very specific for right heart failure, but if the BNP is negative, it is very sensitive tool, and it can rule out right heart failure, and probably you can go and look at other causes for your patient's deterioration. So that's how you can implement the cardiac biomarkers with the right ventricular failure as a diagnosis. So what is the mainstay of diagnosis? The mainstay is 2D echo. Generally we start with transthoracic 2D echo, and we go to transesophageal only if we want any certain detail or we can't get a good window on transthoracic. And what do you see on echo? So if you see an apical 4-chamber view like you are seeing here, you will see that the right ventricle is dilated in the 4-chamber view. When the right ventricular cavity is more than 2/3 of the size of left ventricle, you can say that right ventricle is dilated. So you will see right ventricle dilated. You will also see paradoxical movement of the septum, which is also one of the important findings in right ventricular failure. And you will also see, if you see the parasternal short axis view, you will see that instead of being like a crescent, like this is your left ventricle, and the right ventricle is like this, like a crescent shaped structure, which is just besides the left ventricle. You will see that the right ventricle has increased in its size and the septum has become flat. So the left ventricle, I would say, looks like a D. So D-shaped left ventricle is also a sign which will tell you that there is a right ventricular dilatation and volume and pressure overload. Another imaging technique, that is cardiac MRI, remains the gold standard for diagnosis of right ventricular failure. But unfortunately, for ICU patients or critically ill patients, it's not an option for most of the patients. So that is generally not useful for us in ICU. Now, I also want to discuss the role of right-sided heart catheterization. And as you know, the use of pulmonary artery catheter has gone down over the past several years. But for certain conditions like undifferentiated shock, they may be still useful. The use of pulmonary artery catheter or right heart catheterization for right heart failure is not done very commonly, and it's not validated. But however, you can use this tool for patients who are not improving in spite of all the possible treatment for right heart failure, to find out whether there is any other cause. And it is also useful if you want to diagnose and classify the pulmonary artery hypertension. The PA catheter can also give you guidance while you are titrating your therapies for the right heart failure. So although not a first line of treatment, it can be still used. Suppose you are using PA line for some other purpose, for left ventricular function assessment and tailoring the therapy, then if the patient has a right ventricular failure as well, then probably your right heart catheterization will not give you results as desired. This is because these patients have a significant tricuspid regurgitation. So if you try and monitor cardiac output using thermodilution technique, probably you will get erroneous results. So your results will not be reliable. And if you are using fixed method, which uses the mixed venous oxygen saturation to know the cardiac output, then also you don't know how the critically ill patients utilize the oxygen, and your whole calculation will give you some false result. So for cardiac output monitoring, if you are left ventricular output monitoring, if you are using the right heart catheterization, if right ventricular failure is also an entity in that patient, probably it's not a good idea to go on and use these numbers for your further treatment. So just remember that. So that's about right heart catheterization. There are other minimally invasive techniques like pico or leadco or pulse pressure variation. These all techniques are not validated to be used for right heart failure, right ventricular failure, and there is very limited data. So I can't really give any recommendation to use either of these minimally invasive techniques. So that's about the various diagnostic tests and about the role of right heart catheterization. Now coming to the management of right ventricular failure and general principles. If you say you have to avoid hypoxemia, because hypoxemia will lead to hypoxic pulmonary vasoconstriction, which will increase the pulmonary artery pressure and it will worsen your right heart failure. You have to also try and avoid lactic acidosis, respiratory acidosis by optimizing the metabolic parameters. You have to also try and avoid anemia, because it will lead to inadequate oxygenation of the tissue because of low hemoglobin. So these are the general principles. Now by common sense also, if you think the way we describe the causes, the management is also on the same headings. So you will try to improve your preload, you will try to improve your afterload, and you will try to improve the contractility. So let us discuss them one by one. So first of all, preload in terms of volume assessment. So we have discussed in previous videos also how to assess volume for patients. It is going to be challenging for a patient with right heart failure to assess volume, because the CVP is likely to be erroneously elevated, the IVC is likely to be dilated. So your conventional parameters may not actually give you more information. If it is a chronic process going on, then your peripheries might also be edematous, so that also might not help you get the volume status. But in general, barring a few exceptions being pulmonary embolism and right ventricular infarction, where more fluids are advocated to restore the euvolemia, most of the other causes of right ventricular failure are generally because of the right ventricular dilatation and volume as well as pressure overload. So generally, if you say barring the earlier two causes that I told, giving more fluids is not going to help this patient. What you can do is, if you have a CVP monitoring in place, probably give a small bolus of 250 to 500 ml rapidly over 10-15 minutes and monitor your CVP. And if your CVP goes up after a small fluid challenge, that is an indication that this patient will not benefit by giving more fluids. So that is very important to remember. You can also monitor the echo before and after your fluid challenge and see whether the RV dilatation is more, whether the septum is pushed towards the left side, whether the TAPC has changed, and you can take a decision. Another conservative, probably more practical way is to do a passive leg raising test, which will itself act like a fluid challenge. And if your CVP rises after your passive leg raise, then that also means that the patient is not going to benefit with more fluids. So then in that scenario, you will have to use diuretics to get rid of the excess fluid. You may give boluses or infusion. If patient is not passing adequate urine and you feel that you need to remove more fluid, you may have to do hemofiltration for these patients. So these are all your options in terms of fluid. Now the second thing is to improve the preload, you also have to treat the arrhythmias. And most of these patients will have a dilated right atrium, and as you know, SA node is also there in the right atrium. So these patients are likely to have various atrial arrhythmias. And if you are trying to treat right ventricular failure, probably just rate control is not going to be adequate, because the right ventricular filling is dependent on the atrioventricular synchrony rather than just the rate. So you may have to cardiovert or convert these patients to sinus rhythm, and to do that you may have to give a synchronized shock. You may have to use antiarrhythmics, amiodarone being the most commonly used antiarrhythmic, but you have sotalol and digoxin as well. Your beta blockers and calcium channel blockers are not likely to improve, because they are not going to control your rhythm, they are going to control your rate, and they have a negative inotropic action, which is not going to help in this group of patients. So probably beta blockers and calcium channel blockers are not a good idea for these patients. Now sometimes you may have to do a sequential AV pacing to ensure that the synchrony of atrium and ventricle, they are maintained. So that is also one of your options. And if these patients develop ventricular arrhythmias, then it is to be treated in the same way as you treat any ventricular arrhythmias with your advanced cardiac life support protocols. Now we will discuss what are the options with us to improve the right ventricular contractility. And as you know, we have to avoid hypotension, which will eventually lead to reduced perfusion of the right ventricle and right ventricular infarct. So first we will see what vasopressors we can use, and before we discuss that, we have to learn the concept of PVR to SVR relation. So in normal circumstances, PVR is around 25 and SVR is around 25, equivalent to 25 millimeters of mercury, and SVR is equivalent to around 120 millimeters of mercury. When the patient develops pulmonary hypertension for various reasons, the PVR keeps on rising. If this patient develops hypotension, at certain point the PVR will be more than the SVR, and in that circumstance probably the blood flow to the right ventricle through the coronary will get affected. This is because the coronary arises from the root of aorta, and if the pulmonary resistance is higher than the systemic vascular resistance, then the filling of the right coronary artery and blood supply to the right ventricle will get compromised during the systole, and only blood will flow during the diastole, and at certain stage that will also compromise. So this patient will develop right ventricular infarct. So keeping this in mind, see if you can use any vasopressors which maintains the relationship between the PVR and SVR. That is of vital importance. And keeping this principle in mind, we have two options with us: norepinephrine and vasopressins. And whatever data that we have, they show that a low to moderate dose of norepinephrine has a good action on the PVR to SVR relationship, and it will obviously increase both because it will cause pulmonary as well as systemic vasoconstriction, but the relationship will be maintained, and that's why the right ventricular perfusion will not get compromised. If you use high dose of norepinephrine, then probably the relation may change, and in that case you may have poor right ventricular blood supply. So remember that the advantage of noradrenaline over vasopressin is that it has got some beta-1 action also, so it will improve the contractility also. But if you use it in a higher dose, it will increase the oxygen consumption because of more contractility, and it will lead to more harm than benefit. Coming to vasopressin, so if you use low dose vasopressin, that will also have both pulmonary and systemic vasoconstriction, but the relationship between PVR and SVR will remain the same, and because of that it will be the blood supply to the right ventricle will be maintained. So these are the two choices that you have. Vasopressin does not have a beta-1 action, so it will not improve the contractility. Now you can also improve the contractility by using inotropes. You have three options here. You have dobutamine, milrinone, and levosimendan. Dobutamine is a beta-1 and beta-2 agonist, and when you use it in a lower dose, it will improve the contractility. At the same time, it will reduce PVR and SVR both, but the relationship will be maintained. So it will reduce the peripheral pulmonary vascular resistance, which is of importance here. At the same time, it will improve the contractility. So dobutamine is a good choice. It has got some evidence in right ventricular failure. Only flip side is it can cause arrhythmia, it can cause tachycardia, which leads to increased myocardial oxygen demand, and it may lead to infarct. If it causes hypotension, you may have to use it along with a vasopressor like noradrenaline. Milrinone compared to dobutamine, generally the mechanism is obviously different. It is phosphodiesterase 3 inhibitor, but the action is similar. It also reduces the pulmonary vascular resistance and systemic vascular resistance. It also has an inotropic effect, so it is inodilator, similar to dobutamine. It has less propensity to cause arrhythmias because it does not work on the beta-1 receptors, so that is an advantage, and it has got a favorable profile and good outcome benefit post cardiac transplant, post LVAD implant, to help with the right ventricular failure. So probably milrinone is the drug which is the first line of therapy if you want to use an inodilator. So just remember that. Third option is levosimendan, which is having problems with availability, and that's why it has not come into regular practice, but it is a calcium sensitizer and it also has got a similar effect, but we need more data and regular availability of the drug. Now, if your patient has not responded so far with the medications and therapies that we discussed, then probably the next step is to get a mechanical circulatory support. IABP is the first line of therapy. It has very limited use for right ventricular function, but when LV failure is the main pathology and RV failure is secondary to that, probably IABP will be helpful. IABP will improve the coronary flow, so right ventricular blood supply will improve. IABP will also reduce the afterload for LV, making the LV failure less prominent, and that way it will help the right ventricle. So that is about IVP. You have other option of doing a VA ECMO. VA ECMO is a temporary support, but what it will do is basically it will take out the blood from venous system, bypass the heart and lungs, and push the blood back into the arterial system. And in this way, you can give rest to the heart and lungs, and you can find out the cause, you can find out the definitive modality of treatment, and that way it will buy you time. Another option that you have is right ventricular assist device. So presently there is very limited options available for isolated right ventricular assist device, but there are biventricular devices available, so you can provide biventricular support, and that can be short term or long term, and you need to evaluate these patients whether they are candidate for heart transplant or whether they are candidate for long term ventricular assist device. But these are the last modalities of support that you can offer them, and I have discussed this in the one of the previous videos also, that if you are dealing with anything which you are not very familiar with, probably it is always good to take help from the experts. There is no shame in referring these patients to an expert center, and since I have moved to UK, I have realized that there are pulmonary artery hypertension specialists, so probably I would not hesitate to take help from a pulmonary hypertension specialist, or at least a cardiologist, when I am dealing with a patient with right-sided heart failure, because it is a very challenging entity, and it is very tricky in terms of diagnosis and treatment. I hope you have liked this video. If you like my content, please subscribe to my channel. If you have any suggestions, please put them in the comment box, and I will try to incorporate in my upcoming videos. Thank you for watching this video, and have a nice time.